Good morning, ladies and gentlemen. Welcome to Kinfon Dermatology Classroom. Today I would like to preview a topic on what is new in the pathogenesis of atopic dermatitis. And this is the outline of my presentation. Firstly, what is the mathematics of atopic dermatitis, followed by 3 stories about atopic dermatitis. And the first story is about the itchiness, one of the hallmarks of atopic eczema. As you look at this short video, I believe most of you agree with me that atopic eczema is a very troublesome disease. When we identify the patient has pruritus or itchiness, it's not only important for the diagnosis, but also very important in terms of the sign and symptom that you need to control in the management of atopic eczema. As you look at this study by Betty et al. About the different chronic childhood diseases in terms of their quality of life impairment, and patients with generalized eczema, the quality of life impairment is just second to cerebral palsy. The quality of life impairment is more severe than those seemingly mild disease, seemingly little disease like cystic fibrosis and epilepsy. As we all know, itchiness that associated with atopic eczema, they're not only causing physical problem, they're also causing significant psychosocial and mental disturbance to the family. I'm not surprised at all. Some of the parents with the kids of atopic eczema, one of them have to quit their job to take care of the child with atopic eczema. And on the other hand, patients with moderate to severe atopic eczema, sometimes they have to stop from school and quit their job in order to take care of their own itchy skin problem. As you look at this case, it's a 3-year-old boy presented with generalized lichenified eczema. Again, another video to demonstrate how troublesome is the symptom of atopic eczema. You can see that the itchiness cannot be stopped by the patient effort. They should just keep scratching 7-11 in a day, means 24 hours per day. How are you going to help this group of patients? Are you going to just give them moisturizer with a sedating antihistamine, or you want to combine with non-sedating antihistamine? We know very well that atopic dermatitis itch is different from urticarial-related itch. In any itch, you need to use a combination approach of moisturizer with anti-itch property, steroid, modify the environment, tacrolimus, pimecrolimus, behavior modification. You can use sedating antihistamine at night, but there's no role of using sedating antihistamine in chronic AD itch management. And this is supported by most of the international guidelines suggests that you can use sedating, but only during the acute flare for 7 to 14 days. You can also add on with non-sedating if the patient have concomitant urticarial, cholinergic urticaria, or allergic rhinoconjunctivitis. But don't rely on oral antihistamine for chronic itch management in atopic dermatitis. Some of you might ask, why not? The reason because atopic itch that related to atopic eczema is much more complicated than the itch related to urticarial. And the mediator, indeed, histamine involved in the eczema related itch. And the histamine is not only acting on H1, they are also acting on H4. And most of the antihistamine is only antagonize the H1 and H2 but not H4. At the same time, there are many other cytokines including IL-2, 4, 13, especially IL-31, which is a very potent itch cytokine. Other mediators including proteases, substance P, TRPV1 ion channel activation, TSLP, tryptase, allognesis, and peripheral sensitization. As you look at this slide, you will be able to bird view the mediator involved in eczema-related itch, and H1 is just one of the mechanisms involved. In fact, there are 4 well-recognized mechanisms involved in eczema-related itch. Firstly, there's increase in number of chemical mediators can directly stimulate the itch nerve fibers, either via the histaminergic or non-histaminergic pathway, followed by peripheral sensitization, central sensitization, and habitual. Without further delay, let's take a look at the first mechanism, which is increasing number of pruritogen. This is a cross-sectional view of our skin. We have itch nerve fibers innervate our epidermis. We have mast cells, we have Th cell, keratinocyte, and TRPV1 ion channel. Mast cells, via the tryptase, via the histamine, can directly stimulate the itch nerve fibers. And from Th2, you have IL-4, IL-31, and even changes in the skin temperature, skin pH, that can activate the TRPV1 ion channel. And keratinocyte will produce TSLP. All these have the ability to agitate or excite the itch nerve fibers, and the signal will flow along the unmyelinated C fibers along the spinothalamic tract, get to the cerebral cortex, and initiate the itch, scratch, inflammation, infection cycle. The next mechanism is by peripheral sensitization, as there's a very well studied peripheral sensitization study by Sugere et al. Have shown that if you take a biopsy and stain for the itch nerve fibers over the non-lesional, lesionals, and prurigo nodular area, the density of the peripheral nerve endings is 3.5 times higher in the prurigo nodules than the non-lesional area. Want to know more about the eczema-related itch, please go to www.pediatricdermatology.com.my. Thank you very much for your attention.